So I think that, thanks for sharing that experience. And I think that's really a perfect segue where I'm going to invite Annette to really talk to us about some concrete strategies which she has been testing out with a range of organizations, mostly primary care organizations in British Columbia. Annette, I'm
Great.
just going to pull up your slide and pass it on to
Thank
you.
you. Good.
There you
Can you
go.
hear me all right?
Yes, we can.
Great. Hello, everyone, and thank you again for setting the stage for today's discussion. I'd like everyone to know that I'm located in the traditional and unceded territory of the Musqueam Nation in beautiful BC, and I'm very privileged and honored to be able to be in this beautiful land and to participate in this webinar. So thank you for the invitation to participate. I wanted to move fairly quickly through some of the ways in which EQUIP Healthcare, which is a research program focused on an intervention to try to foster health equity in organizations, is designed and what it focuses on, because that very much influences the shape of the various disruptions and opportunities that I'd like to hold out as examples to prompt your own thinking about this process of organizational change. I had a couple of goals for today, and I'm just trying to advance the slide. Sume, there we go. Yeah, so I'd like to highlight some of the lessons learned from EQUIP Primary Healthcare with an emphasis on this idea of disruption as opportunity, and for us all perhaps to think a little bit more about what we might do in our own organizations. Just very briefly, I've been conducting research now for, I think, several decades, looking at the impacts of racism, stigma, discrimination, and various forms of structural violence over the years. And this has led to us designing an organizational level intervention, which we had the opportunity to implement in 4 primary healthcare clinics in BC and Ontario. And we engaged in that research and had some fairly major insights about the impact of that kind of work, and then refined the intervention and are now in the midst of implementing aspects of it in emergency departments, which is really quite exciting and a real eye-opener. But for today's presentation, I would like to focus on some of the strategies that we use to prompt disruption as opportunity within the primary healthcare sector. I think that it is important for us to orient ourselves within our own organizations to what we mean by equity and equity-oriented healthcare. And as you all know, there has been this rapid proliferation and uptake of calls for health equity within our health authorities, within the health system writ large in Canada. And I think that it is important to drill down and try to articulate for yourselves what that actually means. In the case of EQUIP research program, we definitely bring a structural analysis and want to look at the impacts of multiple intersecting forms of racism, discrimination, and stigma, and what we see as the mismatch between the needs of people who are most affected by health and social inequities and what they encounter when they come for health care. And we do that in some particular ways that I think is important to just take a look at. In the next slide, we have published this conceptual model of the key dimensions of what we're saying is equity-oriented healthcare, and it is founded on 3 key dimensions: trauma and violence-informed care, which really acknowledges the effects of trauma and violence on people's lives; culturally safe care, which we keep returning to some of the roots of cultural safety in relation to reducing power imbalances, racism, and discrimination, and the ways in which they play out in our organizations; and harm reduction, including, as Dr. Tam has called for, reducing structural forms of stigma. And these 3 key dimensions really do overlap, of course, and they can be tailored to really any healthcare setting, as we're finding out in the emerge departments now. And on the right-hand side, of course, there are the 10 strategies that flow from these key dimensions to guide healthcare providers and organizations in terms of prompting their thinking about how to increase capacity to provide equity-oriented care. And so I just want to show you very briefly what we did in terms of our organizational level intervention within these primary healthcare clinics. We invited staff to learn about equity, cultural safety, TVIC, etc. And really a very impactful approach of our intervention is approach 2, which is the organizational integration and tailoring process, which involved discussions among the various interdisciplinary teams, no matter how big or small the clinics were, so that they could think about how to apply some of these strategies in their own context and tailor it specifically. We also found it extremely helpful to kind of have feedbacks of data about patients' health and well-being so that the clinics could make informed decisions about what to prioritize. We, as you can see, asked the leaders and staff within the clinics to identify their own priorities, and were able, through the generous funding of CIHR, to provide a Catalyst grant and access to a practice consultant who could help them to think through what it is that they were going to focus on as they considered how they were going to increase their own capacity for equity-oriented care at their clinics. And so I want to I see, Sume, that we were going to just pause before I focus on some of the concrete strategies that these clinics implemented. Would you like to guide us a little bit in terms of the poll?
Absolutely, thanks for that. So we thought, Annette just shared a couple of strategies for organizations, and we'd like to get a sense from all of you which of these are present in your organization. So we'll just put up a poll here, and you can select all that apply for you. Okay, so we're just going to take a minute there to get you to vote. So we're asking about an explicit commitment to equity, developing supportive organizational structures, policies, and processes, re-envisioning the use of time, attending to power differentials, also tailoring care, actively countering racism and discrimination. So it's looking like for a lot of folks, there seems to be an explicit commitment to equity that seems to be the highest vote so far. There's also a lot of folks who are tailoring their care programs and services to various contexts, which is very encouraging to see, as well as a significant focus on the social determinants of health. I'm seeing less people talking about re-envisioning the use of time, which is really interesting, and that seems to, as well as optimizing the use of place and space. So you may be interested in it as we go through, if you have some specific thoughts around the areas where we're not doing as much work on, how can folks start to think about those things? I'm thinking particularly around re-envisioning the use of time as well as optimal use of place and space. Thank you.
Excellent. Yes, and thank you for running the poll. It is really fascinating to see the areas that people might be able to kind of focus in on in terms of expanding what they're already committed to, knowing that many people on the webinar today, if not all of the people, realize that it's critical to have an explicit commitment to health equity and the social justice aims of healthcare. And yet we can push ourselves to go further. And I'd like to provide some examples of how some primary healthcare clinics that were already oriented to health equity, social determinants of health, social justice, did end up pushing themselves a little bit further, and the process that required. And so this is just a schema of disruptions of opportunity that focuses on the fact that there are going to be tensions that surface in the process of doing this work, particularly, of course, if you're talking about issues of stigma, intersecting forms of racism and discrimination, trauma and violence-informed care, et cetera. Those are obviously very heavy and important topics to consider, but you can approach some of these areas I think, in some very constructive ways that create opportunities. And so I'm going to hold out some examples of that for you. So this slide is just a collection of some visual representations of what the various clinics did as part of their intervention strategies to try to, as I say, push themselves just a little bit further in terms of their equity orientation. And I'm going to go into, I think, 4 examples in a little bit more depth. And again, I'm holding these out as examples that were very appropriate given the local context of these clinics, and these are not necessarily strategies that would apply in other contexts, but I am holding these out as examples to prompt our thinking. And so at one of the big primary healthcare clinics that we worked at, which was located in a large urban center, some of the organizational tailoring and integration discussions really helped to initiate interdisciplinary discussions that were sometimes, I would say, challenging and disruptive in the sense of disrupting the status quo of whose voices were foregrounded, who could participate in decision making, and etc. At this particular clinic, the receptionist played a really lead role in terms of identifying how they could address this idea of equity-oriented healthcare in a very practical sense. So the middle picture is actually a sign that was posted at the reception desk that the receptionist said we ought to take down because they were recognizing that these sort of confrontational and somewhat pejorative signage pieces in their waiting room were potentially setting a certain tone. And so the receptionist's insights were that some of these facets of their waiting room environment, their outside environment at the door, were examples of structural violence. So the MOAs, or the receptionists, worked with clinical staff and leaders at the organization to really try to shift quite consciously and explicitly the tone of voice used over the phone, the signage, and there was a whole process of shifting this process of asking patients to wait in a line outside of the clinic, to get in the mornings, and those were some seemingly simple shifts to make, but as you can all imagine, they required some thinking through about how to manage some of that. I'm going to go to the next example. At all of the clinics, some of the opportunity that we had in this research was to invite patients to tell us a little bit more about their health status in terms of this nexus of chronic pain, mental health issues, substance use, and trauma symptoms. And so in the process of working with the clinics to help them understand the nature of the patient data that we were working with in terms of levels of chronic pain, which were really outstanding in the clinics. One of the clinics decided to address one of the participants' themes, which was, what am I supposed to do about my chronic pain? And so we know that there's a lot of stigma related to chronic pain and a lot of misperceptions about people being drug-seeking or medication-seeking, et cetera. And so at this clinic, there was a real concerted effort to try to address some of that to counteract the stigma related to people who are living with major chronic pain and often substance use issues in this particular site. And so the clinic staff and the receptionists with some patients formed a chronic pain support group. And they decided to go that route to see if they could offer some more strategies for people living with chronic pain. And that was done from a trauma and violence-informed perspective. I can say more about that perhaps a little bit later. At another of the clinics in another part of the country, this particular primary health care clinic realized that they weren't quite doing enough to counteract the ongoing stigma related to substance use. And so they ended up having some major discussions in their organization about how to refine and tweak and in some cases invent new policies related to harm reduction. And I don't just mean about providing safe supplies, but rather to also consider the ways in which, for example, opiate treatment agreements are constructed and the kinds of language and the tone and the formality and the contractual nature of that language. And we, in part of our work, we worked to try to offer up some examples for how some of those treatment agreements can be funneled through an equity lens to make them more respectful, I think, of people's drug use issues. And this will be, I think, the last example I'll hold out before tying things up and opening it up for some discussion. At one of the clinics that was serving high proportions of Indigenous people who were living in the local area, the clinic really wanted to enhance the way in which they were enacting cultural safety. And in addition to having some, in some cases, difficult conversations within their group about how systemic racism continues to play out in relation to urban Indigenous people's health, they decided to foreground some carrier language words in the waiting room. They actually used some of their Catalyst grant to develop a hiring process for an elder to kind of shift the tone and the activities in the waiting room environment. And they also realized that some of the waiting room spaces were not that amenable to making women with young children feel welcome and in some cases safe. And they worked to try to shift the waiting room environment in that way. This slide just gives you a sense of the way in which this kind of an intervention that is really embedded within clinic processes and opens up dialogue within clinics can impact the staff. As I mentioned, it did shift whose voices are typically heard and participate in decision making. Opening up these conversations really does prompt some new levels of conversation. And interestingly, we didn't expect this necessarily, but it did help the clinics to kind of get on the same page in terms of their bottom line commitments to how they wanted to enact health equity. However, in the process, it also surfaced that there were some mismatches with some of the staff in terms of being able to fit into that overall philosophical approach to care, and some staff ended up actually self-selecting out of the opportunity to work at those clinics because of these explicit discussions. So it was all going on. I will just show this because in the context of research, we were able to show, and ours was one of the first studies, I think, to show that providing more equity-oriented health care along these lines predicts improvements in patient health outcomes across time. And you can see some of the self-rated improvements in patient health outcomes over on the right upper corner. And this occurred despite the negative toll of poverty, racism, and discrimination on people's health. And so just briefly, what we learned from tapping into patients' perspectives is that when care is more equity-oriented, that patients do feel more comfortable and confident about the care that they're receiving, which in turn leads to more confidence in their own ability to manage their health issues. And we observed that these things happened, and patients did report less chronic pain symptoms, fewer depression symptoms, fewer trauma symptoms, and an overall improved quality of life, really with the strongest impact seen in quality of life and mental health. And we have published this work, and we're very encouraged by it, realizing these were done in particular settings, and ongoing research needs to study the impacts. And so just to kind of summarize that health equity work is disruptive, but that is definitely a good thing. I think I already mentioned that that this kind of work does necessitate some difficult conversations, and I think this notion of psychological safety, which I see one of the participants has asked us to further define, I think might interface with this idea of how do we deal with some of the difficult conversations and make it a safe process for everybody. And so this slide just shows you what seemed to work well in our experiences in the primary care sector, and that is that tailoring to context and having meaningful discussions was really the way forward. And that I can't say enough about creating opportunities and space even for brief interdisciplinary conversations about some of the small, seemingly low-cost, high-impact strategies that are possible to implement. This slide just is showing you what worked less well, because of course we have some lessons learned. I think we probably weren't disruptive enough. I think we were probably treading a little bit lightly, but trying to take the lead from staff and leaders. It was our first time doing it. We're doing things a little bit differently in the Emerge department now. And staff really wanted more how-to tools. So this is just the last 3 slides are just a glimpse into what we have publicly available for people to draw on at the organizational level, at the health authority level, and at the staff level or clinician level or people that are actually working and providing public health and primary care. So we have developed a range of tools. Some of them are tools and tips about how to respond to discrimination in the workplace. Others are about how to implement trauma and violence-informed care. We actually, at the request of clinicians, developed health equity pocket cards about say this, don't say that, to offer up particular phrasing in terms of how to counteract, for example, substance use stigma. And we have developed some heuristics about doing equity walkthroughs. In some cases, some of the organizations we work with now are calling them cultural safety walkthroughs. You could call them harm reduction walkthroughs. It doesn't really matter. It's the process that you engage in. Sometimes we invite patients to do this with us as well, or clients, and it's extremely illuminating. So we have also developed these online educational modules that we're in the process of refining that delve a little bit more deeply into some of these strategies. And finally, this is my summary slide in terms of the lessons learned, and perhaps this can be a fulcrum for our discussion for the last 15 minutes or so. And that is to say that our big insights are that we cannot just provide education and individual staff training, that there must be organizational support and the conditions. For example, staff in our studies have been freed up to participate in some of these discussions, even for a few minutes at a time. So they're backfilled, and of course that's not always the case in many healthcare agencies, and so there's all sorts of conditions that have to be put into place at the leadership level. I do think that some of what I'm holding out as possibilities are seen as contrary to some short-term efficiency initiatives, and so of course we have to negotiate that within the systems we're located in, and there is an opportunity for some whole system transformation, but that said, I think, as I say, there are some very seemingly small but profoundly meaningful shifts that can occur. And what we learn from patients is that there is no small change. So on that note, I think perhaps we can revisit this idea of disruption and overall culture change and how to balance that with also concrete, smaller kinds of changes that can occur. I've provided a reference list at the end if anyone is interested.
Thank you so much for that, Annette. I think in just listening to you, a lot of what you're sharing is really resonating. So I know your work was done in a clinical setting and with clinics, and a lot of folks on the line maybe working in non-clinical sense. But I think a lot of what you share can really be transferred to other sorts of health sector organizations, and I would argue other kinds of organizations in general. So thank you very much for that. One of the pieces you talked about, which is the fact that some of this work is often contrary to
Yes.
short-term efficiencies. I know when we spoke as part of the organizational capacity initiative, lots of folks on the line definitely shared that a lot of the times the work they're doing is um, it's perceived as threatening, the efficiencies which the health sector would like. So again, that piece is definitely resonating.